Dr. Umar Raja. He's the consultant endocrinologist and diabetologist at Shifa International Hospital, Islamabad. He's also current vice president, Pakistan Endocrine Society, Punjab. Sir, please come on stage.
Okay. Thank you, Salman. KZP, it seems like that if you want to live longer, eat less, um, avoid animal proteins, and take a metformin and SGLT2 inhibitors. So I can see it music to the ears of the pharma companies already. Uh, uh, I'm Dr. Umar Raja. I'm going to present on the LDL cholesterol, how low should we go. Uh, for this midsummer endocrine meeting, I was actually planning just to stay low, not any presentation. Till Faisal asked me to present, and I can't say no to few person. Amir Saab is one of them. Well difficult to ask no to him. Abbas is another, and Faisal is of course. So why did I choose the LDL cholesterol levels? And one of the reasons is that while I was a registrar in UK, at that time we were thinking that the lower the HbA1cs, the better it is. So we were trying to even aim HbA1c of 6% till we have got a core study and advanced study. And we then knew, even with the UK GP data, that there is a U-shaped mortality or U-shaped association with HbA1c and mortality. And then we think about that, okay, what about the blood pressure? The lower the blood pressure is, the better it is. And then with a sprint study, we knew that if you bring your blood pressure to lower than 120 systolic, there is an increased risk of fall. So what about the LDL cholesterol? Is it a U-shaped pattern or is it just a linear pattern? And this also brings me to about 5 years ago, because 5 years ago in there was the midsummer update in Nathiagari. Professor Rashid asked me to give a presentation on the latest dyslipidemia guidelines. And part of that sort of basically making the presentation, a few presentations have made my practice change, and that was one of them. So this is what I was mentioning to Professor Rashid is a part 2 to that presentation as well. So the topic is how low we should go regarding LDL cholesterol. These are my disclosures. This is the overview. So I'm going to go look at the evidence behind the cholesterol reduction and cardiovascular risk reduction. Part 2 is going to be considered about, okay, what the evidence show about how low we can go for LDL cholesterol, and then what does the latest guidelines say. Okay, so it's about half a century regarding the research about LDL cholesterol rolling and reduction in cardiovascular disease, starting from the study by Oslo regarding diet, which caused a 14% reduction in total cholesterol and a 25% reduction in coronary heart disease. And then in 1990s, I think that's where the trend changed regarding dyslipidemia with the advent of statins. And you can see with the 4S, the reduction in LDL cholesterol is 35%, and you see a 30% reduction in coronary heart disease. And then even with the newer PCKS9 trials like Fourier, where you can see an LDL cholesterol reduction of 62 milligram per deciliter, you see a further 20% reduction in coronary heart disease. So it's nearly half a century now about the evidence behind the cholesterol rolling and the reduction in the cardiovascular disease. So what is the evidence? So these are the primary studies, and here you can see these are CARDS, ASPEN, heart protection study, or heart studies. So it's comparing the low dose, you can say the statin like Torva 10 milligram versus placebo, simvastatin 40 milligram versus placebo, and you can see fair amount of numbers. You can see the subject with the diabetes, so CARDS study, 100% of them were diabetic, HPS around 28% were diabetic, and you see somewhere between a 25, so about 1/4 to 1/3 reduction in coronary heart disease with the statins. If you look at the secondary prevention studies, and again you can see different studies like 4S, KL, lipid, HPS. Similarly, there are studies of simvastatin, pravastatin, atorvastatin, fair amount of numbers, and you will see the evidence is much stronger than with the secondary prevention studies, where about 25 to 50% reduction in coronary heart disease with the cholesterol reduction. And then mid 2000s, you will see the high dose result with the high dose statins versus the low dose statins, And I'm going to discuss some of those studies later on as well. So starting with the PROVIS study, where you're giving the high dose statin like Atova 80 versus Prava 40 or Sima 40 versus, and then 80 milligram versus placebo, or Atova 80 milligram versus Atova 10 milligram. And you see that the higher doses of statin produced another 25% reduction in the coronary heart disease. So what did we know about, I mean, this is an overview of the statin studies, and what does we know? So what we know was regarding these studies that for every 10,000 patients treated with statins, 500 cardiovascular disease events will be avoided. For every 10,000 patients you're treating with statins, 1 will develop rhabdomyolysis, 5 will develop myopathy, and 75 will develop diabetes mellitus. So it's better to check HbA1c or glucose levels annually. The mechanism is still unclear, but we knew that there are higher risk in patients with prediabetes. We knew that there are certain statins which might be considerably safer than the other statins, but most of the diabetes associations are still recommending statins just because the number need to, or the benefit from statin is much higher than the number need to harm to cause diabetes. Okay, so then let's go to the part 2, and the part 2 is about what's the evidence behind how low we should go for the LDL cholesterol. And for me, the way that you are going to discuss your, or you are going to compare your evidence is to look at what we call the zoological data. So what's the contemporary LDL cholesterol levels are, let's say in wild animals, what about the epidemiological data, and what about the trial data shows. So here you can see what's the average LDL cholesterol is in humans versus animals. And remember, we are actually a hunter-gatherer society. I mean, this is what we are supposed to be, hunter-gatherer, rather than urbanized humans, where if you look at urbanized or adult American, the average LDL cholesterol is around 200. Look at the LDL cholesterol level in, say, horse, it's around about 100, 110. Similarly, black rhinoceros, about 70. No one have heard about rhinoceros dying of heart attacks. I would believe that. Wild primates, baboon, about 100. And even if you look at hunter-gatherer humans, it's around about 100, 110, 120. And I think that's one of the reasons. That's why if you look at the initial guidelines, some of them were saying that less than LDL cholesterol, less than 135 is what you are looking for. Okay, as compared to, say, urbanized humans where the LDL cholesterol is around about 200. So that's when you're comparing if you contemporary mammals, wild animals, or even domesticated animals. So the PROVIT is actually one of the first studies which have shown the benefits of intensive versus moderate statin therapy. So here atorvastatin 80 milligram was compared with pravastatin 40 milligram. And look at the LDL cholesterol figure. With Prava 40 milligram, the baseline LDL cholesterol was 100. With atorvastatin, the baseline LDL cholesterol was around 60. And you can see around 25% relative risk reduction in favor of atorvastatin 80 milligram. Then came IMPROVE-IT study, where Sima monotherapy was compared with simvastatin ezetimibe combination. And you can see a hazard risk of 0.936. So this is statistically significant in favor of simvastatin ezetimibe combination. But the important thing is, so apologies if you can't see that query, but in the baseline, in the Sima group, the baseline LDL cholesterol was 93, and after 1 year, it went down to 69. In ezetimibe Sima group, the baseline LDL cholesterol is 93, and it have come down to 53. And you can see whether it's a cardiovascular disease, myocardial infarction, unstable angina, revascularization. In all the markers, you will see benefit in terms of Simva ezetimibe combinations. And the important thing actually is that there was this theoretical what is the risk, or there was fear that maybe there might be increased risk of hemorrhagic stroke or neurocognitive defect if we are going to lower the LDL cholesterol. And here you can see when you're comparing even, I mean, whichever side effect you're seeing, neurocognitive defects, hemorrhagic stroke, rhabdomyolysis, you see the p-value is pretty much non-significant. Again, showing that lower LDL cholesterol is safe. The next evidence, I think, came from the PCSK9 inhibitors trials. So I'm going to go first to the foliar trial, which is a study of evirocumab versus placebo. And here again, if you look at this slide, the p-value is significant. So basically, you'll see somewhere about 15 to 20% risk reduction with evirocumab versus placebo. But important thing actually is look at the LDL reduction again. So with placebo, the baseline is around 90, you can see. With evirocumab, there was an absolute reduction in LDL reduction cholesterol of 56 milligram per deciliter to around about 30 milligram per deciliter. And here you can again see a hazard ratio of 0.85 or 0.80 based on different endpoints, again showing that the lower LDL, the lowest the LDL, the better it is. But then look at the subgroup analysis. So these are the patients whose baseline LDL cholesterol was less than 70. So in placebo, the median LDL cholesterol was 66 milligram per deciliter. With evirocumab, it have come down right to 21 milligram per deciliter. That is 0.5 millimoles. So 66% mean LDL cholesterol reduction. And again, look at the result. Look at the forest plot. Again, even if your LDL cholesterol is less than 70, the trends favor evirocumab. So the lower the LDL cholesterol, right up to even 20 milligram, the better you'll get beneficial effect in terms of coronary heart disease reduction. And again, about safety. So again, here you can see the side effects. So look at the purple figure. And Dr. Khurshid, this is in response to your question. So look at the purple figure. This is where the LDL cholesterol is less than 0.5. And here you can see, you can't see the changes between different values at all, meaning that even up to 20 milligram, you can go safely. So it's look like rather than a U-shaped pattern, it's actually a linear pattern. You can go right up to 0.5 millimoles per liter with the LDL cholesterol. So it seems like there's a linear trend as compared to say with HbA1c or with maybe even BP, where it's actually a U-shaped pattern. Odyssey was actually the phase 3 trial study of evirocumab with placebo. And again, here you can see the baseline LDL cholesterol about 100 milligram. You can see with evirocumab, there was a 54 milligram per deciliter reduction to around 53 milligram per deciliter. And again, you can see an absolute risk reduction of 1.6%. And this is a meta-analysis of 8 randomized controlled trial evaluating 38,000 patients. And the important thing is, the lowest your LDL cholesterol is, you will see the patient at risk of major cardiovascular event, you will see the benefit right from less than 50, then 50 to 75, then 75 to 100. So it looks like that this is again a linear pattern going on there as well. So again, that's showing the lowest your LDL cholesterol is, mean the cleaner your arteries are going to be. And again, with this study, you can see the LDL cholesterol and atheroma formation, and you can see the percentage atheroma volume, and these are different studies, and you can see that the lower the LDL cholesterol is, the percentage atheroma volume is actually going down here toward negative side. So what did we know then? So in 1990s, with the advent of simvastatin, 4S, we knew high is bad. Between 1996 to 2002, when lipid care and HPS trial came, we knew that average is not good. Mid 2000s, high dose statin versus low dose statins, we knew low is better. Combination therapies versus monotherapy, we knew that even low is even better. And with then PCSK9 and say microRNAs inhibitors, we knew that lowest is the best. Okay, so part 2 was going through about how can or what's the evidence here regarding how low can we go. Part 3, okay, we knew that the lowest the LDL is, the better it is. But the important thing is how can we achieve this lowest LDL cholesterol level. And the strategy is quite simple. Post ACS or coronary artery disease patient, start on statin. The problem is we don't tend to optimize that. I think if you optimize it enough, if the LDL cholesterol is less than 70, fair enough. If it's more than 70, you can think about adding ezetimibe. And then if it's still more than 70, then you can think about using other things like PCSK9 inhibitors. But the problem with that actually is we don't have a PCSK9 inhibitors, and even if we had it, it's going to be very, very expensive. So what about the statin? How low can statin cause the LDL reduction? And this is a comparative slide. What you are thinking about, anything in red is more than 40% reduction in LDL cholesterol, and that is what you are going to think. So your Terva 20 will bring it to more than 40%. Your rosuvastatin more than 40, or rosuvastatin 10 will give rise to more than 40% reduction in LDL cholesterol. So on average, there's a rule of 6. So if you double the dose of any statin, it will increase by, or it will reduce the LDL cholesterol by 6%. So it's, for example, simvastatin 27%, you double the dose, then the reduction in LDL cholesterol is around 32%. Double the dose, it will increase by another 6% to 37%, and so forth with rovastatin or with rovastatin. You add ezetimibe, you'll see another 15% reduction. So for example, if you are thinking about rosuva 5 milligram, so we knew it caused around about 38% reduction. So it will cause rosuva 5 plus ezetimibe 10, somewhere around about 50% more reduction. And that's what you are looking for. So here again, you can see a systemic review and meta-analysis looking at the comparatively strength or therapeutic equivalence of statins. And here you can see the two main statins that tend to stand out is actually atorvastatin and rosuvastatin. So again, so how do we define high, moderate, and low intensity? High intensity is anything that drop your LDL cholesterol by more than 50%. And it's actually two statins, atorva 40 to 80 or rosuva 20 to 40. Moderate intensity is which reduce LDL cholesterol reduction by 30 to less than 50%. And here you can see atorva 10 to 20, fruva 40 milligram, rosuva 5 to 10, simva 20 to 40 milligram, or pitavra statin 2 to 4 milligram. And low intensity is LDL cholesterol less than 30%. So again, simva 10 milligram or pitava 1 milligram. And the recommendation or guidelines are that for all the patient with AMI, you should be starting with high intensity statin treatment and start them as early as possible and use highest tolerated dose. You should consider low intensity statin only in patients who are at increased risk of AE from statins, or elderly, or with hepatic or renal impairment. And if they have statin intolerance, then consider treatment with ezetimibe. Or you can go for maybe once weekly statin with ezetimibe, or thrice weekly statin with ezetimibe, and of course with the lowest dose. So just to summarize this part, if you look at the moderate intensity, will give you an average LDL reduction of 30%, high intensity statin, an average LDL reduction of 50%, high intensity statins plus ezetimibe around 65%, and that is equivalent to a PCSK9 inhibitors. Can we achieve it? So this is actually data from states, and this is published in JAMA. And what they did was they actually look at, okay, how many people have achieved the HbA1 LDL cholesterol less than 70 milligram per deciliter, and then how much of high intensity statin and ezetimibe they were on. So you see only very few of those people were on a high intensity statin and ezetimibe. That's in state around 1%. They tried to intensify it, and what they showed was that up to 85% can achieve an LDL cholesterol of less than 70 with high intensity statin and ezetimibe. Around 15% where you are going to require some other means. So majority, if you bring it down or bring up the dose, you can actually achieve an LDL cholesterol of less than 70%. So having said that, the last part of my talk is going to be, so what does the guidelines say? So again, the 2016 ES guidelines were, they differentiate their patient into then very high risk, where they were aiming for LDL cholesterol of less than 70, high cardiovascular risk, where they are aiming for LDL cholesterol of less than 100 milligram per deciliters, and then they are type 1 or type 2 with target organ damage, where again they were at that time saying LDL cholesterol of less than 70 milligram or 50% reduction in LDL cholesterol, or there was a score risk as well. And these are the risk categories, so very high risk, either progressive atherosclerosis disease or diabetes mellitus with target organ damage or severe CKD or calculated score of more than 10%. High risk are type 2 diabetes. We don't have the risk factors, or moderate CKD or score between 5 and 10%. and moderate risk is scored between 1 and less than 5%. The way that is changed in 2021 EHC guidelines are that number one, they are using different scores now for different patients. So if they are healthy people less than 70 years of age, then you should be using score 2. But in healthy patient more than 70 years, you are going to use a score OP. The other thing that they have recommended is that the target is different based on your age. So if your age is less than 50, then a score to score of more than 7.5% should be considering for adding a statin. If your age is between 50 to 70, then the score 2 of more than 10% should be considered. And for score OP, more than 15% for age more than 70%. So it's quite wisely an age-based strategy as well. This is an example of what the score chart look like. So basically, there is this systolic blood pressure, whether you smoke or not, age, and then based on that, you put them on which risk categories they are on. But the gist of the guidelines are that they are again saying, well, for a very high risk, you are now aiming for an LDL cholesterol of 55 milligram per deciliter or less, and a 50% reduction of LDL cholesterol based on what the newest evidence says. And it's similar with type 2 diabetes who are very high risk, or type 2 diabetes more than 40 years of age at high risk. Again, the treatment goal is around about, for those, the treatment goal is around about 70 milligrams or less. Same thing, but the main important thing actually is that, again, these are guidelines are saying if LDL cholesterol goal is not reached with high intensity statin, add a combination therapy with ezetimibe. What about CKD? So you can use it in CKD 3 to 5. If these people are already on statin ezetimibe or statin ezetimibe combination at the time of dialysis, then continuation of these drugs should be considered for treating patient with atherosclerosis disease. You can only think of stopping them if they are free of atherosclerosis disease and they have achieved a dialysis. What about ACE guidelines? So ACE pretty much even in 2017 was using a cutoff figure of LDL cholesterol less than 55 based on whether it's an extreme risk or very high risk, where things are saying about less than 70 or high risk or moderate risk. So it's pretty much the same. But what you are looking for is they have added now a triglyceride levels as well on top of that. And again, they are saying the same thing, extreme risk or very high risk or high moderate, use lifestyle and high intensity statin. And then if it remains above the designated target, add ezetimibe, or you can add other options as well. But in our setup, I think the best option is going to be an ezetimibe combination as well. And similarly, in case of the statins intolerance, you can acknowledge patient symptoms. If considered significant, stop the statin. If symptom resolve, you can re-challenge, maybe try lower dose, maybe use dosing less frequent, 1 to 3 times a week, or sometimes use a low dose with ezetimibe, so you can do that, or use ezetimibe as a monotherapy as well. To summarize, there is a strong epidemiological and trial-based evidence regarding LDL cholesterol reduction in cardiovascular risk reduction. We knew that the current evidence point toward lowering LDL cholesterol to less than 50 milligram per deciliter. And we knew that recent guidelines recommend high-intensity statin, like rosuvastatin with ezetimibe as a first-line drug combination to achieve LDL cholesterol targets. I think I'm finished on time, 6 months earlier. So thank you very much. I'm happy to take any questions.